everyone. Welcome to today's live broadcast, New Specificities in the Antiphospholipid Syndrome, the importance of testing for APS, PT, and anti-beta-2 domain 1 antibodies. I am Brenda Kelly Kim of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by Innova Diagnostics. Innova Diagnostics is a privately held company headquartered in San Diego, California. The company was founded in 1987 and has over 360 team members around the world. We are leaders in the development and commercialization of new autoimmune technologies and diagnostic markers. For more than 25 years, the Innova Diagnostics team has collaborated with clinical researchers to develop biomarkers that help advance the care of autoimmune disease patients. We are redefining autoimmunity, leveraging our innovative spirit to deliver solutions that anticipate the needs of the laboratories and improve efficiency and quality of testing. For more information, please visit www.innovadx.com. We do have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit your questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many of your questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. And if you have any technical problems hearing or viewing this presentation properly, please click on the support button at the top right of your presentation window, or submit your problems through the green Q&A button lower left. I would now like to introduce today's speaker. Dr. Maria Laura Bertolaccini was born in Rosario, Argentina, where she graduated from the medical school at the National University of Rosario. She joined the lupus unit in 1996 as a clinical research fellow. In 2004, she was awarded her PhD degree by King's College London. Dr. Bertolaccini is the managing editor of Lupus, an international journal. She is the co-chair of the standardization subcommittee on lupus anticoagulant and antiphospholipid antibodies at the International Society for Thrombosis and Hemostasis, chairman of the Antiphospholipid Syndrome Laboratory Diagnostics and Trends Task Force, and executive committee member of the Antiphospholipid Syndrome Alliance for Clinical Trials and International Networking, APS Action. Dr. Bertolaccini has published 84 peer-reviewed papers, 2 books, 11 book chapters, and presented more than 85 abstracts at national and international meetings. So we'll now turn you over to Laura for her presentation.
So thank you very much. In the next few minutes, I'm going to present you all the data available on the importance of testing for anti-phosphatidylserine-prothrombin and anti-beta-2 domain 1 antibodies. So we all know that in the clinical setting, the most tested antibodies are those directed to cardiolipin, anti-beta-2, and the lupus anticoagulant. But although these tests are the best available and they are clinically useful in the majority of the cases, they do not recognize the wide range of specificities for the antiphospholipid syndrome. So there is a constant search for new specificities. Most of the studies have been focused on anti-beta-2 glycoprotein 1 due to the fact that they have been shown to be more specific than anticardiolipin antibodies. And these have been shown since very, very early studies, as you can see in this slide. So beta-2 glycoprotein 1 is a natural anticoagulant, and we all know that is an essential requirement to differentiate pathogenic from non-pathogenic anticardiolipin antibodies. Beta-2 glycoprotein 1 is composed by 5 domains, with the domain 5 responsible for the binding to phospholipids, and domain 1 that is exposed when the molecule suffers a conformational change. So, in the search for the epitopes of anti-beta-2 glycoprotein 1 antibodies, antibodies to all the domains of the beta-2 have been reported. However, most of the studies showed that this epitope was located in domain 1, and therefore the attention was focused on this part of the molecule. Early studies from 2005 from the group by the lab show that there were two types of anti-beta-2 glycoprotein 1 antibodies, those that recognize domain 1 that were responsible for lupus anticoagulant activity and were highly associated with thrombosis, and another group with heterogeneous reactivity for all the domains. Several studies have been published in the literature referring to the clinical significance of testing for anti-domain 1 antibodies, but one of the most important papers was published back in 2009, where the group of the lab again showed that anti-domain 1 was present in 55% of the patients positive for anti-beta-2 glycoprotein 1 antibodies. 83% had thrombosis, and they were also associated with pregnancy morbidity. In a recent study from the group of Professor Pengo, by using inhibition assays, they show that antibodies to domain 1 were more frequently present in those patients with triple positivity for antiphospholipid antibodies. A recent study also from the group of Andreoli et al., they tried to characterize clinically antiphospholipid directed to beta-2 glycoprotein 1, and they have shown, as you can see in the left of the screen, that from all the group of anti-beta-2 glycoprotein 1 in the figure of the center representing the domain 1, and in the figure of the right, those antibodies directed to domain 4 and 5. So they show that most of the antibodies directed to beta-2 glycoprotein 1 were directed in reality to anti-domain 1. What is more important from antibodies directed to domain 1 is that these antibodies are pathogenic when infused into a mouse, in a mouse model of thrombosis. As you can see on the left of this slide, animals injected with anti-domain 1 show a higher thrombus size, and in the right, a higher tissue factor activity in the carotid artery endothelium. In a recent study from our group, we also show that these antibodies can be helpful in discriminating patients with the so-called seronegative antiphospholipid syndrome. We show that 7.5% of the patients who were negative for all antiphospholipid profile but were having clinical features of the antiphospholipid syndrome were also found to be positive for antibodies anti-domain 1. So prothrombin is another target important for antiphospholipid antibodies. As we all know, prothrombin is a plasma protein that circulates in plasma at a concentration of 2.5 micromole per liter. Prothrombin is activated by the prothrombinase complex into thrombin that in turn activates protein C and protein S, starting the fibrinolytic pathway. An analogy with the antibodies to beta-2 glycoprotein 1 has been also described for antiprothrombin antibodies. Prothrombin should be exposed to a particular surface to suffer a conformational change and expose epitopes that are detected by antiphospholipid antibodies. There are two ways of detecting these antibodies. One is coating prothrombin onto an irradiated plate that will give the negative surface, and another is by coating prothrombin over a phosphatidylserine layer, also providing a negative layer that will allow the epitope expression. So our earlier studies in 2005 showed that antiprothrombin on the left and antiphosphatidylserine-prothrombin on the right were associated with thrombosis. These antibodies were not only more frequently found in patients with thrombosis than in those without, but also the titers were higher. So our first question was that fine, there are two ways of detecting the same antibodies, but when we tried to correlate them, we failed. Although you can see in this slide that many patients had both antibodies, there were many discrepancies, with some patients presenting one antibody and others presenting the other. So what is more interesting from these antibodies is that none of these antibodies interfere with prothrombin antigen level in plasma, nor with prothrombin antigen activity, suggesting that these antibodies do not affect the function of prothrombin in plasma. So what do we know about epitopes for antiprothrombin antibodies? Well, we do not know a lot about it. The epitopes are not known, they may be heterogeneous, and they could be binding to any part of the molecule. Our very preliminary data show that antibodies to phosphatidylserine-prothrombin are unable to recognize fragment 1 in solid phase. This could be due to two factors. One, that the epitope is not located in fragment 1, or two, that the antibodies need the presence of the whole molecule of prothrombin to recognize the epitope that may be covered. So we have two different antibodies, APT and APSPT, that have been shown to have different immunological characteristics. We don't know much about the epitope, but what do we know about the clinical significance? So we decided to undergo a systematic review of the literature in a search to find what was reported regarding these antibodies. As you can see in this slide, when we analyzed the studies available on antiprothrombin, prothrombin coated in solid phase, we found a wide range of results, with some studies showing association between the presence of these antibodies and thrombosis, and others failing to confirm this association. When we analyzed the data available for antiphosphatidylserine-prothrombin, the association to thrombosis was clearer, with almost all but one of the studies showing a significant association that was stronger for venous thrombosis, as you can see in the graph on the right. Another important question is the association between these antibodies and the lupus anticoagulant activity. There have been very early reports in a patient with hypoprothrombemia that presented antibodies antiprothrombin and a prolongation of the coagulation test. Later on, in 1991, Vivers et al. Suggested that antibodies to prothrombin could be a cofactor for the lupus anticoagulant activity. The group from Professor Atsumi showed that from all their patients APSPT positive, 95% were shown to be lupus anticoagulant positive, suggesting that APSPT may serve as one of the confirmatory tests for lupus anticoagulant. So we decided to analyze this theory, and we studied a group of patients with and without lupus anticoagulant. While we shown that patients with lupus anticoagulant had more frequently antiprothrombin and antiphosphatidylserine-prothrombin antibodies, we also were able to demonstrate that antiphosphatidylserine-prothrombin were independent of the presence of lupus anticoagulant and were independent risk factors for thrombosis. So we have lots of antibodies, most of them being under research. So we tried to determine what was the diagnostic precision or the accuracy for diagnosis, finding a profile that would help us in this task. So we evaluated 23 possible combinations of antiphospholipid antibodies. This slide is just to show you some of the combinations that we use in a search for which profile would help us in better identifying the antiphospholipid syndrome. So the diagnostic accuracy was best when we used the combination of testing for lupus anticoagulant, anti-beta-2 glycoprotein 1, and anti-phosphatidylserine-prothrombin. This diagnostic accuracy was not only best for antiphospholipid syndrome as a whole, but also when we search for thrombosis and pregnancy loss independently. Surprisingly, this diagnostic accuracy was even better than that we could see by using the current classification laboratory criteria, lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1. What is more important is that we were also able to demonstrate that each of these antibodies was a thrombotic risk factor or an independent thrombotic risk factor, and the addition of an antibody to another one would increase the risk with the presence of anti-beta-2, anti-phosphatidylserine-prothrombin, and lupus anticoagulant, increasing this risk 23-fold. So how do we measure risk? This is one of the big questions that we have in the clinic. So in an attempt to define risk or trying to stratify patients according to risk, we designed the Global Antiphospholipid Syndrome Score. So this risk score was derived from the combination of several independent risk factors, being anti-phosphatidylserine-prothrombin, one of the risk factors found to be independent. So what did we see by applying this score? We saw in a population of lupus that this score was able to discriminate patients with thrombosis from those without. We saw in a population of primary antiphospholipid syndrome that this score would discriminate patients with thrombosis from those without thrombosis. And what was more important, it was able to discriminate those patients with recurrences from those without. We also applied this global antiphospholipid syndrome score in a prospective cohort of patients with antiphospholipid syndrome, and we show that an increase of 3 points in the score during follow-up was a risk factor for thrombotic events. The percentage of time free from a thrombotic event was lower and statistically lower in patients who didn't have an increase in the gaps during the follow-up. What is more important, are these APSPT pathogenic? Well, the group of Professor Atsumi again showed that phosphatidylserine-dependent antiprothrombin antibodies induced tissue factor expression on procoagulant cells in vitro, and this effect is produced via the p38 MAP kinase pathway. In our laboratory, we have shown in another animal model of inferior vena cava ligature that animals infused with antiphosphatidylserine-prothrombin induce or have a higher, bigger thrombus and a heavier thrombus. Unfortunately, this data is under embargo and therefore I cannot present it today, but it's very interesting and confirm the pathogenic effect of antiphosphatidylserine-prothrombin. So in conclusion, regarding anti-domain 1 antibodies, we show that cross-sectional and retrospective data show that anti-domain 1 positivity is associated with thrombosis and pregnancy morbidity. Of course, importantly, animal models show pathogenicity of anti-domain 1 antibodies. However, the frequency of patients positive for anti-domain 1 and negative for anti-beta-2 is still not established and definitely deserves more research, and the value of anti-domain 1 as the sole antibody is still to be determined. Regarding antiphosphatidylserine-prothrombin, we know that antiphosphatidylserine-prothrombin, but not antiprothrombin in solid phase, are independent risk factors for thrombosis, are independent from the presence of lupus anticoagulant, and along with lupus anticoagulant and anti-beta-2 glycoprotein 1 antibodies, this APSPT can offer the best diagnostic accuracy for APS, thrombosis, and pregnancy complications. So we believe that by including APSPT as a laboratory criteria for APS, we may achieve a better diagnostic performance and an improved thrombotic risk assessment. The most important message I would like to leave with you today is that the clinical view on antiphospholipid antibodies has entirely changed, and the value of antiphospholipid antibodies have evolved from being markers of disease to being important independent risk factors for thrombosis. The risk is associated to the presence, and it seems that it's not to the level of the antibodies, and therefore these patients presenting antibodies should be closely monitored. Thank you very much.
Thank you for that informative presentation. Before we get started on the question and answer session, I would like to remind our audience how to submit their questions. You can submit questions by typing them in the Q&A box, which can be found on the green Q&A button at the lower left of the presentation window. We'll try to get to as many of your questions as we can. And we do have a first question coming in from our audience. We have a question: is there any lab in the U.S. currently offering the Domain 1 test?
Well, my understanding is that there is a lab in Oakland, California. Mason Labs are offering this test at the moment.
Great, that's good to know. Our next question: at this time, how would you recommend using Domain 1 in a clinical setting? Would you recommend testing triple positive patients for Domain 1?
Well, I think it is clear that once you have the diagnosis, you need to test more antibodies. So I probably not recommend testing in addition to the other antibodies. However, these antibodies may be helpful if you have a patient with the clinical features that has been shown to be negative for all the currently used antibodies, and perhaps testing for Domain 1 and APSPT may help in identifying the antiphospholipid syndrome.
Great, thank you. Our next question: how would you treat Domain 1 positive patients versus patients who are Domain 1 negative? Would you alter the course of therapy?
Well, probably not. I don't know. I think you do not treat antibodies, but you treat the disease. So once you have the diagnosis, you need to treat accordingly. The antibodies are tools that should be put into the clinical settings, so the clinical manifestations. So no, probably I would not change the course of treatment at the moment, but yes, I would test for these antibodies to help in the diagnosis.
Thank you. We have another question. It sounds like the evidence for PSPT is strong. Will it be included as a classification criteria test in the near future?
Well, evidence for APSPT is really strong, and what is more important, there is a sort of stable data coming out from different groups which make it stronger. So inclusion of APSPT as part of the laboratory criteria will be discussed in Istanbul in the next antiphospholipid meeting. So we will see. Stay tuned.
Great. Looking forward to that. We have another question. Are commercial assays available for Domain 1 autoantibodies?
Well, there is a commercial assay available from Inova for Domain 1 autoantibodies. Yes.
Thank you for that answer. I think we do still have some more questions coming in. Yes, we do. Can you test for APS-PT while the patient is on anticoagulation therapy?
Yes, you can. As we showed in the slides before, antibodies do not interfere with prothrombin, and there shouldn't be any alteration of the antibody during anticoagulation. So yes, you can test them.
Great. Good to know. Our next question. Once APS is diagnosed, is there any purpose to remeasuring APL autoantibodies? What is the effect of an APL autolab on the fetus, excluding spontaneous abortion?
Well, we use, at least at St. Thomas's, they use retesting of APL maybe once a year. It's just a case of monitoring rather from diagnosis. Once the patient is diagnosed, the diagnosis is clear. So usually patients are treated accordingly, and even if they become negative, there is a little bit of controversy if they can be put out of treatment or not. There are no clinical trials that show that these patients are at less risk. So you remeasure antiphospholipid antibodies as sort of monitoring, but even if the antibodies become negative, most of the groups are still treating these patients once they have the diagnosis. Regarding the effect of antiphospholipid in the fetus, excluding spontaneous abortion, well, there is a lot of data emerging. So antiphospholipid antibodies have been related to early miscarriages, to fetal death, to preeclampsia, to placental insufficiency, and recent data from Professor Girardi is showing that antiphospholipid antibodies may cross the blood-brain barrier in the fetus, and probably this will be a long-term effect of APL in the babies. So this is data that she is working on, and hopefully we will have some answers to this in the near future.
Great, thank you. We're getting lots of good input and questions from our audience. I just want to encourage our audience that this is the time to ask any questions of Laura and her presentation today. Clicking on the green Q&A button will bring those questions right to us. And we would love to hear from you with those questions. Okay. Laura, do you have any other comments for our audience while we're waiting for a couple of questions?
No, I think there is a lot of work to be done on antiphospholipid antibodies. Anti-domain 1 are a very important and a very hot target for antiphospholipid antibodies, and a lot of data on anti-domain 1 will be presented in Istanbul as well. And regarding APS-PT, we believe that they are risk factors associated with thrombosis, and hopefully this marker will be included in the laboratory criteria soon.
Great. It does sound like a very exciting area of research with lots of information coming soon. We do have another question from our audience. Do domain 1 auto labs differ?
Sorry, can you repeat that one?
Yes. Do domain 1 auto labs differ when being presented? I'm sorry, I can't see the question. Do domain 1 auto labs differ whether or not the patient has SLE?
SLE. No, 30% of patients with lupus have antiphospholipid antibodies. So many of the studies on domain 1 and APS-PT have been performed in patients with lupus. Now there is an agreement that lupus and APS are two different conditions. So even if domain 1 can be presented in a patient with SLE, the antibodies are similar and behave in a similar way.
Great. Thank you for that. I don't see any more questions in our queue from our audience. I do, at this point, want to let Laura wrap up our presentation. Any final comments or advice that she has for our audience? Oh, we do have a question. I'm sorry. Is there an importance of IgM antibodies of PSPT?
Well, IgM antibodies to PSPT have been highly associated with the lupus anticoagulant. So we are trying to investigate further if this association is because they share some sort of function or if they are independently associated. But IgM and PSPT have been highly correlated with the presence of lupus anticoagulant.
Great. Thanks for that. I do want to also thank our sponsor today, Innova Diagnostics, for making today's educational webcast possible, as well as Dr. Bertolaccini for taking her time today to explain this area of research to us. Today's webcast will be available for on-demand viewing through May of 2016. You'll receive an email from LabRoots alerting you when this webcast will be available for replay, and we invite you to forward that announcement to your colleagues who may have missed today's live event. Thank you again to Dr. Bertolaccini and Innova Diagnostics for this webcast. Hope to see you again next time. Goodbye.